Just by means of orientation, mitral valve prolapse. Prolapse is an anatomic description, but really the underlying pathology is myxomatous degeneration of the mitral valve. And although there are some clinical associations like atypical chest pain and palpitations, the real clinical implication of importance has to do with premature degeneration of the mitral valve and mitral regurgitation. For any patient with chronic mitral regurgitation, there's a series of events that can happen. And early in the stage of disease with mild or moderate chronic mitral regurgitation, there are really no clinically important hemodynamic sequelae. The disease is well tolerated and not really of clinical importance. Eventually, with the development of chronic severe mitral regurgitation, there is a compensated phase followed by a decompensated phase. In the compensated phase, there's progressive left atrial and left ventricular enlargement. And the left atrial enlargement allows maintenance of normal left atrial and pulmonary venous pressures, so patients remain asymptomatic from that standpoint despite high pressure and high volume blood being ejected into the left atrium. And with left ventricular enlargement, this allows maintenance of, establishment of a higher stroke volume and therefore maintenance of a normal forward cardiac output despite the severity of mitral regurgitation. Eventually, though, there is a decompensated phase with permanent left ventricular systolic dysfunction and clinical presentation with heart failure. And indications, as you know, for intervention in the setting of chronic severe mitral regurgitation have to do with symptoms, LV enlargement, or dramatic LV enlargement, or LV systolic dysfunction, pulmonary hypertension, or new onset atrial fibrillation. Differing in the ACC-AHA guidelines and in the ESC guidelines with respect to the level of evidence to support the intervention, prophylactic mitral valve repair also can be supported, meaning patients with a relatively normal left ventricle, left atrium, and lack of symptoms can be referred for surgery. So the quantification of MR, of course, is very subjective, and the problem with that is that any one single measure to quantify MR is flawed, and the best way to quantify MR is with an integrative approach where multiple factors are evaluated. That integrative approach for MR assessment involves looking for ancillary evidence of MR. So by means of a long clinical introduction to the clinical observation that I'm going to share, the presence of chronic severe MR will result in left atrial and left ventricular enlargement, and the use of left atrial and left ventricular enlargement ought to be used to clarify that the MR truly is severe. That having been said, I've seen, and I think others have seen, some patients who have mitral valve prolapse and left atrial and sometimes left ventricular enlargement without severe MR. This is a patient who I follow who has significant posterior leaflet mitral valve prolapse and lots of MR to go along with the left atrial enlargement. This is another patient who I see who has bileaflet myxomatous changes of the mitral valve in a Barlow's type pattern, a globular left ventricle with preserved systolic function, and dramatic left atrial involvement. But unlike the previous patient, this patient has, at most, mild mitral regurgitation. So based on this clinical observation that there are patients who have mitral valve prolapse, there are patients who appear among them to have significant atrial enlargement, and I believe that there are some of them that do not have significant left atrial enlargement. After thinking about these people for a while, I accumulated a group of 9 patients who I follow who fit this pattern. And for the most part, they're middle-aged patients ranging in age from the mid to late 40s to the early 60s. There are both men and women. For the most part, they have Barlow's type pattern of prolapse with bileaflet myxomatous degeneration, 2 patients with isolated posterior leaflet prolapse and fibroelastic deficiency. But all of them have in common hemodynamically insignificant mitral regurgitation, trace or mild MR. And in the course of my clinical evaluation of them, all have been, as far as I can do it, fairly rigorously tested to look for more MR with serial echocardiograms, transesophageal echocardiograms, and exercise echoes trying to provoke mitral regurgitation, all without the provocation or the identification of more MR. When I looked at their quantified left atrial and left ventricular enlargement, and ejection fraction, all had normal EF, all had been followed for some period of time. These same numbers here are now coded where white is normal, green is mildly abnormal, yellow is moderately abnormal, and red fits in the category of severely abnormal. So 7 of the 9 patients had, by ASE and ESC criteria, severe left atrial enlargement by volume index to body surface area, and the other 2 had moderate left atrial enlargement by left atrial volume index. At the time that they were first identified, all patients were asymptomatic, and in assessing for any other cause of left atrial enlargement, none had hypertension, none had diastolic heart failure, or other causes that should lead to atrial enlargement. And none at the time of presentation had atrial fibrillation. In the follow-up of about 5 years, 1 patient developed hypertension a couple years after diagnosis, after he'd been established with atrial enlargement, and 2 fairly late into following them have developed atrial fibrillation, still in the absence of more than mild mitral regurgitation. So there are some extra valvular manifestations of myxomatous mitral valve disease. Obviously, mitral valve prolapse can occur in the setting of other diseases, ones that have abnormal collagen, like Marfan syndrome or Ehlers-Danlos syndrome. But there are also known extravalvular manifestations of isolated mitral valve prolapse with skeletal abnormalities such as pectus excavatum, ascending aorta dilation in the absence of other markers of Marfan syndrome, or even abnormalities of the left ventricle with focal hypertrophy, and some people feel even focal cardiomyopathy. So my questions, after making what I think is a valid clinical observation, is there an intrinsic abnormality in left atrial tissue among some patients with mitral valve prolapse, and how are you going to go about defining this, those of you who do knock out genes and animals and smart things like that. This has great clinical implications. From the standpoint of valvular heart disease, patients who have atrial enlargement and mitral valve prolapse are at risk of being sent to surgery in an era of prophylactic mitral valve repair based on the belief that atrial enlargement is a marker of more severe MR. And second, 2 of these 9 patients have developed atrial fibrillation. So without the implication of elevated left atrial pressure, but rather with simple left atrial enlargement, there may be some nidus for arrhythmia as well. Thank you.